So let's go over some key aspects of the shoulder girdle. I want you to start thinking of the shoulder not just in terms of the glenohumeral joint, but I want you to think of 5 separate joints. Obviously the glenohumeral joint, but also the acromioclavicular joint, which is a gliding or a planar joint. The glenohumeral joint was a ball and socket joint. We have the sternoclavicular joint, which is a saddle joint, and we have 2 physiological joints, which are very important. Posterior here, we have the scapulothoracic joint, and anterior, just underneath the clavicle, here we have the subacromial joint. So, we start looking at the shoulder. Consider this as one functional unit. Now, if we actually look at the glenohumeral joint here, quite often people will get anterior instability. What they don't realize is anterior instability is quite often caused by posterior restrictions in the capsule. If that happens, we have a little ligament underneath here, which is the inferior glenohumeral ligament. It's kind of like a sling that sits in here, or a hammock, and that holds the head of the humerus in place. The problem is when this gets dysfunctional due to restrictions posterior, this ligament starts to change its position, then we're susceptible to impingement syndromes. Now, if we look over just a little bit farther here at the AC joint here, we'll see that this is supposed to glide. And think of this joint more of like a pivot point, so the scapula can actually function and rotate a little bit better. And then we start getting into the sternoclavicular joint. Now, both of these joints here are extremely susceptible to either trauma or osteoarthritic changes. There is a lot you can do for joints even though they become osteoarthritic. We get in and we get onto any kind of synovial joint, and we have to realize what happens here. Over a period of time with osteoarthritic changes, we'll get a decrease in synovial fluid. Now, as we get that decrease, basically we start to get decreased space in between the fibers around the capsule. This starts to come in and folds develop within the joint itself. This means that the joint will lose some of its integrity. So if we get in there through exercise and motion and manual therapy, we'll actually start to increase the production of synovial fluid. We may not be able to change the cartilage degeneration, but as we have an increase in the synovial fluid, we'll get better function in the joint itself. And this is really, really important. Now, if we look back at the physiological joint posterior here, in terms of the scapulothoracic joint, essentially we've got the scapula gliding over top of the ribs here. Now, realize that there are 17 different muscles that actually attach to the scapula here, so it's a really important structure. And most of the problems that are created are through dyskinesis and basically abnormal motion patterns. Now, let's go to the front here, and if we look at this physiological space, the subacromial joint right underneath the clavicle here, essentially we have a bursa that goes through here, and we also have the tendon that comes through the subscapularis. This is a very common place in terms of impingement. So we have to consider these joints and not just look at the soft tissue of the shoulder or look at a singular joint, but consider that this entire area works as one synergistic unit. This really is powerful work if you actually consider the shoulder girdle as a complex.